Welcome to the MRCPology channel for a quick review, understanding, and revision of the topic. Imagine a patient walking into clinic with slowness, a reduced arm swing, a soft voice, a small handwriting pattern, and a tremor that is most obvious when the hand is resting in the lap. The exam question is asking you to recognize Parkinson's disease, but the deeper question is asking you to understand why dopamine loss causes reduced movement. Parkinson's disease is a progressive synucleinopathy. That means there is abnormal accumulation of a protein called alpha-synuclein inside neurons. These aggregates form Lewy bodies. The key motor problem is degeneration of dopaminergic neurons in the Substantia nigra pars compacta. Dopaminergic simply means dopamine producing. The Substantia nigra pars compacta sends dopamine to the striatum, and this nigrostriatal dopamine normally helps the basal ganglia select, initiate, and smooth movement. So the chain is Substantia nigra dopamine is lost, basal ganglia circuits become dysfunctional, thalamic drive to the motor cortex falls, and the patient develops bradykinesia, rigidity, rest tremor, and later postural instability. To understand Parkinson's disease properly, think of the basal ganglia as a movement control system with two main pathways. One pathway helps movement go ahead. The other pathway applies the brakes to unwanted movement. In simple terms, there is a direct pathway, which is the go pathway, and an indirect pathway, which is the stop pathway or brake pathway. Let us start with the direct pathway. The direct pathway facilitates movement and helps initiate movement. Imagine you are driving a car. The cortex is you deciding that movement should happen. The striatum is like your foot acting on the driving system. The GPI, which means the internal segment of the globus pallidus, acts like an internal brake on the thalamus. Normally, GPI inhibits the thalamus, so if the striatum inhibits GPI, the foot comes off the brake. The thalamus is released from inhibition, and the thalamus can then stimulate the motor cortex. The result is increased movement. So the direct pathway is cortex stimulates striatum, striatum inhibits GPI, GPI stops braking the thalamus stimulates the motor cortex, and movement increases. Dopamine is the chief regulator here. Dopamine stimulates D1 receptors on striatal neurons. D1 stimulation increases direct pathway activity. In the car analogy, more dopamine means more accelerator effect, more happy, more speed. When this pathway is underactive, there is reduced stimulation of the motor cortex, and the patient develops Parkinsonism, especially bradykinesia and hypokinesia. Now move to the indirect pathway. The indirect pathway is the stop pathway or the brake pathway. Its job is to suppress unwanted movement patterns. Again, imagine the cortex as you and the striatum as your hand acting on the handbrake system. The cortex stimulates the striatum. The striatum then inhibits the GPE, which means the external segment of the globus pallidus. If the GP is inhibited, the subthalamic nucleus becomes more active. The subthalamic nucleus is like the internal machinery of the brake system. It then activates the GPI. The GPI becomes more active, applies more inhibition to the thalamus, and movement decreases. So the indirect pathway is cortex stimulates striatum, striatum inhibits GPE, the subthalamic nucleus becomes more active, GPI becomes more active, the thalamus is inhibited, motor cortex stimulation falls, and movement decreases. Dopamine normally inhibits the indirect pathway through D2 receptors, so dopamine reduces the brakes. Again, more dopamine means more happy, more speed. If the indirect pathway is not properly controlled, motor output becomes abnormal. In Parkinson's disease, because dopamine is lost, the brake pathway becomes too strong. By contrast, in hyperkinetic movement disorders, abnormal basal ganglia output can lead to an overactive motor cortex and unwanted movements. Now bring both pathways together. The thalamus is like the car engine that stimulates the motor cortex and gives the final approval for movement. The GPI acts as the brake for the thalamus. If GPI activity is high, the thalamus is strongly inhibited and the motor cortex receives less drive. If GPI activity is reduced, the thalamus is released and movement becomes easier. Dopamine stimulates D1 receptors on striatal neurons. These D1 neurons inhibit GPI, so the thalamus is released from inhibition and movement increases. Dopamine also inhibits the D2 pathway, meaning it suppresses the indirect pathway. That reduces GPI braking, releases the thalamus again, and increases movement. So dopamine has a beautifully coordinated action. It strengthens the accelerator and weakens the brakes. The substantia nigra produces dopamine to the striatum, and that dopamine makes movement easier. In Parkinson's disease, substantia nigra dopamine is lost. That means there is less accelerator through the direct pathway and stronger brakes through the indirect pathway. The thalamus is over-inhibited, the motor cortex is understimulated, and movement becomes reduced. Imagine driving a car with the handbrake on. The engine may still be working, but the car struggles to move smoothly. Now let us translate that into pathophysiology. Loss of nigrostriatal dopamine causes reduced stimulation of the direct pathway and increased activity of the indirect pathway. This leads to excessive inhibitory output from the GPI and SNR to the thalamus. SNR means substantia nigra pars reticulata, another basal ganglia output nucleus that, like GPI, can inhibit thalamic and brainstem motor targets. Excessive GPI and SNR inhibition suppresses the thalamus. The thalamus then sends less excitatory drive to the motor cortex. The final result is bradykinesia and hypokinesia. Bradykinesia means slowness of movement. Hypokinesia means reduced amplitude or poverty of movement. These are central to Parkinson's disease. In MRCP, always remember that bradykinesia is essential for the diagnosis of Parkinsonism. Tremor alone is not enough. Alpha-synuclein aggregation forms Lewy bodies, and the disease process is not limited to motor circuits. Lewy pathology can spread beyond the nigrostriatal pathway and involve autonomic limbic, sleep, olfactory, and cortical networks. That is why non-motor symptoms often precede the classical motor features. This is clinically important. Parkinson's disease is not just a tremor disease. It is a multi-system neurodegenerative condition. Now let's go through the clinical features by linking each feature back to the mechanism. The key motor abnormality begins with nigrostriatal dopamine loss. This causes decreased direct pathway activity and increased indirect pathway activity. GPI and SNR inhibition of the thalamus becomes excessive. The motor cortex receives less drive. That is why patients develop bradykinesia, hypokinesia, masked facies, micrographia, and hypophonia. Masked facies means reduced facial expression. It happens because automatic facial movements become reduced. Micrographia means small handwriting. The patient may start with normal-sized writing, but the letters become progressively smaller because motor amplitude is not maintained. Hypophonia means a soft voice, again due to reduced motor drive and reduced automatic scaling of movement. Rigidity is different from weakness. In rigidity, there is increased resistance to passive movement throughout the range of motion. It is not velocity dependent in the same way as spasticity. In Parkinson's disease, abnormal basal ganglia output increases tonic alpha motor neuron activity through brainstem and spinal pathways. Alpha motor neurons are the final motor neurons that activate skeletal muscle. The result is uniform resistance when the examiner passively moves the limb. When tremor is superimposed on rigidity, you feel cogwheeling. Cogwheel rigidity is not a separate type of rigidity. It is rigidity with a ratchet-like interruption caused by tremor. Rest tremor occurs because dopamine loss destabilizes basal ganglia thalamocortical oscillatory loops. In simple language, the motor control circuits begin to fire rhythmically at rest. The tremor is classically a resting tremor and may reduce when the patient performs a voluntary movement because voluntary action recruits cortical motor programs that temporarily override the oscillation. MRCP trap. A tremor that is worse during action or posture is not the classic Parkinson's rest tremor. Think about essential tremor, drug-induced tremor, hyperthyroidism, cerebellar disease, or anxiety, depending on the clinical context. Postural instability and freezing usually occur later. These features reflect involvement of axial motor circuits, cholinergic pedunculopontine pathways, and impaired automatic motor sequencing. The pedunculopontine nucleus is a brainstem locomotor region involved in gait and postural control. When these systems are affected, patients can develop falls, festination, and freezing. Festination means the patient takes progressively faster, shorter steps, almost as if they are chasing their center of gravity. Freezing is the sudden inability to initiate or continue walking, commonly at doorways, when turning, or in crowded spaces. This is why Parkinson's patients may describe their feet as being glued to the floor. Now the non-motor features. Non-motor symptoms come from Lewy pathology outside the nigrostriatal pathway. Gut and autonomic involvement causes constipation, urinary dysfunction, and orthostatic hypotension. Orthostatic hypotension means a drop in blood pressure on standing, causing dizziness, falls, or syncope. Olfactory bulb involvement causes anosmia, meaning loss of smell. Brainstem sleep nuclei involvement causes REM sleep behavior disorder. Normally during REM sleep, the body is paralyzed, but in REM sleep behavior disorder, that normal paralysis fails, so patients may act out dreams, shout, kick, or punch during sleep. Limbic and cortical spread can cause depression, hallucinations, and cognitive impairment. The limbic system is involved in mood and emotion, while cortical involvement explains later cognitive problems. In exams, REM sleep behavior disorder, constipation, anosmia, and depression can all appear years before the motor syndrome. Do not confuse Parkinson's disease with drug-induced Parkinsonism. Drug-induced Parkinsonism often follows dopamine receptor blocking drugs such as antipsychotics or antiemetics. It is often more symmetrical and may have less classic rest tremor. The key clue is the medication history. Now let us move to treatment. The treatment of Parkinson's disease is mainly symptomatic. The aim is to restore dopaminergic tone, improve motor function, reduce off time, and manage complications without causing intolerable adverse effects. The most effective symptomatic treatment is levodopa combined with a peripheral decarboxylase inhibitor. Levodopa crosses the blood-brain barrier. Dopamine itself does not cross the blood-brain barrier well, so we give the precursor, levodopa. Once levodopa reaches the striatum, it is converted into dopamine. This helps restore thalamocortical drive and gives the strongest benefit for bradykinesia and rigidity. The decarboxylase inhibitor is added to reduce conversion of levodopa into dopamine outside the brain. Examples include carbidopa or benzerazide, depending on the preparation. Peripheral dopamine formation causes side effects such as nausea, vomiting, and hypotension. By inhibiting peripheral decarboxylation, more levodopa reaches the brain and fewer peripheral adverse effects occur. But long-term levodopa treatment can produce motor complications. Chronic pulsatile stimulation of dopamine receptors leads to receptor and signaling maladaptation. The patient may develop wearing off, on-off fluctuations, and peak dose dyskinesias. Wearing off means each dose works for a shorter time before the next dose is due. On-off fluctuations mean the patient can switch unpredictably between mobile and immobile states. Peak dose dyskinesias are involuntary movements that occur when levodopa effect is at its highest. Other adverse effects of levodopa include nausea, orthostatic hypotension, hallucinations, confusion, and sleepiness. In an older patient, hallucinations and confusion can become a major limiting factor. Next, dopamine agonists. Dopamine agonists include pramipexole, ropinirole, rhodogotein, and apomorphine. These drugs directly stimulate dopamine receptors, so they are less dependent on surviving nigrostriatal terminals. They can be useful early in selected younger patients or as an adjunct to reduce off time. But the side effects are very important for MRCP. Dopamine agonists can stimulate limbic D3 receptors and cause impulse control disorders. These include gambling, shopping, hypersexuality, and binge eating. This is a classic exam clue. A patient with Parkinson's disease starts gambling excessively after a dopamine agonist is introduced. Mesolimbic and cortical stimulation can cause hallucinations and psychosis. Hypothalamic and brainstem effects can cause somnolence and sleep attacks. Patients may suddenly fall asleep, which is particularly dangerous when driving. Dopamine agonists can also cause nausea, postural hypotension, and ankle edema. MRCP trap. Do not miss impulse control disorder in a patient taking a dopamine agonist. It is not simply a behavioral problem. It is a recognized dopaminergic adverse effect. Now, MAOB inhibitors. MAOB inhibitors include rasagiline, selegiline, and safinamide. MAOB stands for monoamine oxidase B, an enzyme that breaks down dopamine in the central nervous system. By blocking dopamine breakdown, these drugs modestly prolong the effect of endogenous dopamine and levodopa-derived dopamine. Their benefit is usually modest compared with levodopa. Side effects are dopaminergic and include insomnia, nausea, hallucinations, and dyskinesia, especially when combined with levodopa. Dyskinesia can worsen because the overall dopaminergic effect is increased. Now, COMT inhibitors. COMT inhibitors include entacapone and opicapone. COMT stands for catechol-O-methyltransferase, an enzyme involved in peripheral levodopa metabolism. By reducing peripheral levodopa breakdown, COMT inhibitors produce smoother levodopa levels and reduce wearing off. The adverse effects are important. They can cause diarrhea and orange urine. They can also worsen dyskinesia and hallucinations because levodopa exposure rises. So if a patient develops troublesome dyskinesia after adding a COMT inhibitor, the mechanism is increased levodopa availability. Now, amantadine. Amantadine enhances dopaminergic tone and antagonizes NMDA glutamatergic transmission. NMDA receptors are glutamate receptors involved in excitatory neurotransmission and plasticity. In Parkinson's disease, amantadine is particularly useful because it can help dyskinesia. The side effects are exam-relevant: confusion, hallucinations, ankle edema, and livedo reticularis. Livedo reticularis is a mottled, lace-like purple discoloration of the skin. Now, anticholinergics. Anticholinergics reduce relative striatal cholinergic excess. In the striatum, there is a balance between dopamine and acetylcholine. When dopamine falls, cholinergic activity becomes relatively excessive. Anticholinergic drugs can therefore help tremor, but they are not usually the best treatment for bradykinesia. Avoid anticholinergics in older patients. They can cause dry mouth, urinary retention, constipation, blurred vision, and cognitive impairment. In an older patient with Parkinson's disease and memory problems, anticholinergics can worsen confusion and precipitate delirium. Finally, deep brain stimulation. Deep brain stimulation is usually targeted at the subthalamic nucleus, or GPI. STN means subthalamic nucleus. GPI means the internal segment of the globus pallidus. Stimulation functionally modulates abnormal basal ganglia output. It can improve tremor, rigidity, OFF time, and dyskinesia in levodopa-responsive disease. That last phrase matters: levodopa-responsive disease. Deep brain stimulation works best when the patient's symptoms still respond to levodopa, but medication complications such as dyskinesia or OFF periods have become difficult to manage. If symptoms do not respond to levodopa, they are less likely to respond well to deep brain stimulation. Risks include infection, hemorrhage, dysarthria, and mood or cognitive effects. Dysarthria means impaired articulation of speech. Cognitive and psychiatric assessment is therefore important before considering surgery. If you remember one thing, remember this: dopamine normally increases movement by stimulating the direct go pathway and inhibiting the indirect brake pathway. In Parkinson's disease, dopamine is lost, so the accelerator is weak and the brakes are strong. The thalamus is overinhibited, the motor cortex is underdriven, and the patient becomes slow, rigid, and hypokinetic. Quick recall: a patient has slowness, masked facies, micrographia, and rigidity. Explain the basal ganglia mechanism that produces bradykinesia in Parkinson's disease. The answer is loss of nigrostriatal dopamine, causing reduced D1-mediated direct pathway activity and increased D2-mediated indirect pathway activity. This increases GPI and SNR inhibitory output to the thalamus, reduces thalamocortical stimulation, and produces bradykinesia and hypokinesia. A younger patient with Parkinson's disease is started on a dopamine agonist and later develops compulsive gambling, hypersexuality, ankle swelling, and sudden sleep attacks. What is the drug class and why does this happen? The answer is a dopamine agonist, such as pramipexole, ropinirole, rotigotine, or apomorphine. It directly stimulates dopamine receptors, including limbic D3 pathways causing impulse control disorders, and hypothalamic or brainstem pathways causing somnolence and sleep attacks. Do subscribe to the channel for further videos.